Hello guys, welcome back. This is Dr. Ranjith, your pathology educator and Unacademy. So here we are with one more video of pathology nuggets. It's a case number 15 which we are discussing for postgraduates. And the routine goes as usual. I'll be showing you an history and possibility based on the history and few images of the case. And I'll be describing the image. I want you to mentally describe the image yourself and just make sure if you're in sync. I'll be highlighting the important points while description. Those are the points like checklist I want you to note and look at for every case you're going to see. And then at the end of the case, we'll be seeing a possible diagnosis if I can arrive, or a differential diagnosis, and whatever ways I can differentiate from their close mimics, either with the help of histomorphology or with the help of IHCs. And I'll use the IHCs wherever it's essential. I'll give the images as well, so that we'll get used to the interpretation of IHCs as well. Fine. And there'll be classes for post-graduation, dedicated for postgraduates in histopathology and hematology. We'll be seeing cases in YouTubes and the theory classes, how to approach to every case organ wise. We're done with endometrium and cervix, and we'll be doing ovary in the month of November. That's this month. Fine. So we're ready. We can go ahead with the case. Today's case is a 43-year-old breast mass. See, breast is one of the important things I want every pathology postgraduate to excel at. Right? Rosen is an amazing book. I want you to go through whenever you have time, because reporting in breast masses, breast lesion becomes a very important thing when you are in private practice. If you are diagnosing and reporting histopath, almost every day at least you'll have 2 to 3 breast biopsies, because that's the commonest one, and the awareness is more. Because of the awareness, even a tiny benign lesion also comes to the notice of the doctor and they take a biopsy. And one thing I would advise is, as much as possible, try to avoid FNACs of breast. FNAC is only one organ where it is good and its diagnostic is thyroid. Rest of every organ, please approach and ask for a biopsy. So let's go ahead to the case. Right? So I'm going to have 4 images here. It's an excision specimen, not a true cut biopsy. The first image is this. I want you to mentally describe the image, and I'll also describe the image. Just let's see if it matches. So what I'm seeing here is definitely this is a terminal ductal lobular unit. 2 of them are seen here classically. What is seen extra in addition is there are few glands which kind of looks abnormal. Let's go to higher power and decide if this is abnormal or not. What's seen in the background is stoma. There are lots and lots of dense stoma. It looks collagenous. So might be abnormal, could be normal, right? So here in looking at this image, what all could be my differential diagnosis? It could be a radial scar. The first thing the dense stoma makes me think it could be a radial scar. Your sclerosing adenosis radial scar. Or it could be a neoplasia with lots of the dense finding. That also could be a lesion, right? It could be a desmoplasia in the background, right? Let's go ahead. Second image again, it's kind of looking like lobules only, but a little bit increase in the glandularity. This lobular architecture is kind of distorted. I'm having lots of glands, tiny glands, and it's kind of something looks like that. There's some secretion inside most of the glands. Let's go and look at the high power, whether it's benign or malignant, fine? Again, same thing. What I can point out here is the secretions. The secretions are quite staggering for me here. I have the secretions almost everything. The glands are tiny, they kind of dispersed. Intermix is what I'm seeing, the collagen, the desmoplasia, or the fibrosis, whatever it might be. So to say a breast duct lobular unit is benign or malignant, I'm sure all of you rely on one finding, which is the presence or absence of myoepithelial lining. So in this image at least, I couldn't see myoepithelial lining, right? I'll maybe look at this image, this gland focused. I'm seeing a single layer, not like that, almost everywhere. I'm seeing only a single layer gland, fine. We didn't do a marker here, we didn't do a myoepithelial marker. I'll just give you an information that P63, if it's done, it will be negative because there is no myoepithelial cells. Look at one more image. Again, same thing. Lots of fibrous tissue, and I have glands with no myoepithelial cells. And I gave you information of, okay, there are no myoepithelial cells based on in the IHC as well. So I want to diagnose here and differential diagnose here. First, there is lack of myoepithelial cells. Second, the cells are not pleomorphic. Though there is no myoepithelial cell, everything looks fine. I don't have epithelial hyperplasia as well. It's almost single lining cells, right? So there are 2 main differential diagnoses for this condition. One is my tubular carcinoma of breast, which is completely low grade, looks like benign, no myoepithelial cells, tiny tubules like this. Second is my microglial adenosis, right? So this was a case of microglial adenosis which was diagnosed, and this might most likely be mistaken for a tubular carcinoma of breast. I don't want you to do that. we'll go to each and every histomorphology of microglial adenosis, and we have differences between tubular adenoma, tubular carcinoma, and many other findings. Fine. We have tables how to differentiate both. So microglial adenosis, there will be small, uniform, open and rounded glands. That's more important. They'll be rounded. In a tubular carcinoma, it will be angular. Why it's going to be angular? Let's assume this is a gland, and this gland is invading. It's carcinoma, right? So it'll have all the fibers, desmoplasia fibers. So the fibers kind of pushes this and becomes an angulated gland. Right? The fibers pushes the gland and becomes angulated. Here there's no fibrosis, no desmoplasia. So what we saw, the collagen was just normal collagen. That's all. The normal stroma of the breast. That's it. And it looks very thick here. Maybe the section was thick. That's all. Fine. Lined by uniform. That's more important. Cuboidal and mostly flat. Most of them have flat lining as well. Nuclei are also flattened, parallel to the circumference of the gland. You might have a cytoplasm clear to eosinophilic. We didn't have much of a cytoplasm here. It's predominantly the nuclei. Fine. This is very, very important. I want you to remember this forever. A microglial adenosis will have a colloid-like secretion in the lumen. Tubular carcinoma will not have. There are two things which can have a pink color secretion inside. One more disease is collagenous spirulosis. I have shared an image of that in the Telegram group. I want you to go through the Telegram group. Because collagenous spirulosis is a very, very close differential diagnosis for a cribriform DCAS. They exactly look like a cribriform pattern. Center allows secretion, collagenous spirulosis, right? Very, very important. Secretion is there, think of a benign condition. Right? Same with microglial adenosis, same with collagenous spirulosis, fine? Cytologically, they will be bland. We didn't have nucleoli at all. There's no mitotic figures. We saw at least some 100 glands in all the images. None of them had ATP or much. No mitotic figures also, fine? Next. The distribution is half as half. That's what we saw. Few of them were looking like a duct lobular unit. Few of them were scattered. It was a very irregular distribution. No lobular grouping most of the time. So what we saw as a lobular grouping is nothing but the normal lobules, fine? And it's not stellate. It's not stellate means I have a finding here, a gland, and then surrounded by that multiple glands. I don't have that appearance. It's a completely fully distributed glands, very, very ill-formed, not properly circumscribed also. That makes me think it could be malignant, fine? So keep this in mind. Hafsa distribution might be seen in microglial adenosis. Background of fibrous or fatty tissue. I won't see a background fatty or fibrous tissue, but what happens is the normal breast parenchyma itself can become a bit thicker. Though it's not fibroplasia, though it's not desmoplasia, it might become thicker. It will have a collagenous appearance, right? So have a look at them also. And the most important thing is there will be no myoepithelial layer. If the myoepithelial layer is present, it's not a microglial adenosis. Sclerosing adenosis can have myoepithelial layer. Radial scar can have myoepithelial layer. Microglial adenosis will not have a myoepithelial layer. That becomes a very important differential diagnosis on tubular carcinoma of breast. Tubular carcinoma will not be rounded, angulated. Tubular carcinoma again will have pleomorphism, though it's low grade. Tubular carcinoma will not have a central secretion. In addition to that, if you have a doubt, do these markers. Microglial adenosis, the one marker which I prefer always is EMA. EMA will be positive in your tubular carcinoma, will be negative in your microglial adenosis. S-centered will be diffusely positive, that can also help. CK and EGFR, generally we don't have these combinations, so we'll ignore that, right? S-centered in EMA will help me to differentiate microglial adenosis. So I have a lesion which is very, very close mimical of a tubular carcinoma of breast, or it could be just a normal benign lesion. So we have to know the differences between all of them. The first thing, I hope it's a bit smaller, but I think you'll be able to appreciate them. The difference between tubular carcinoma and microglial adenosis. There are lots of tables like this. I'll share them in the live classes where we are going to learn more in the Unacademy app, where these are very, very important for a practicing pathologist to come to a conclusion. A stellate infiltrating gland in tubular carcinoma, like known as a nodular diffuse thing, right? A round to oval ducts with pointed ends, that's more important, and a gaping lumen. I said it will be pointed, right? It will be uniform round. It will not be pointed. It will not be angulated at all. This might help me. This will help me a lot. Empty lumens in tubular carcinoma and eosinophilic secretion present, it's microglial adenosis. And the cells, as you know, the pleomorphs and everything, EMA will help me a lot when I'm going to go for an IHC. EMA positive is tubular carcinoma, EMA negative microglial adenosis. Because I'm not a person who's going to rely more on ERPR and Hertinu, because that might sometimes confirm my diagnosis. But EMA is going to be completely positive in tubular carcinoma. EMA will be pitch dark negative in my microglial adenosis. That will help you. Basement membrane, if you have a staining for basement membrane, if you have collagen staining in your IHC in your lab, you can go ahead and do it. Basement membrane will be absent. Obviously in tubular carcinoma it will be absent. It will be variably present in your microglial adenosis. Fine. That's the first difference. I have few more things which I can differentiate, which are close differential diagnosis for microglial adenosis. We'll go ahead and have a look at that. Sclerosing adenosis versus microglial adenosis. Again, both will have irregularly half-a distribution. The most important finding is the myoepithelial layer. It will be present in my sclerosing adenosis and it's going to be completely absent in the microglial adenosis. That's the most important differentiating point. But when you're going to diagnose sclerosing adenosis, since there's lots of fibrosis behind, so the glands might become angulated. More than saying it's a differential diagnosis for a microglial adenosis, it could be a DD for a tubular carcinoma of breast. There also, I'm going to use the bioepithelial marker only. Do a P63. Personally, I believe in myosin heavy chain. That's a better marker than P63. Right? If you have myosin heavy chain, do that. Or P63 also is a very good marker. It'll be prominent. It'll be present in sclerosing adenosis. It'll be absent in microglial adenosis as well as your tubular carcinoma of breast. You have a collagenous stroma or adipose tissue in microglial adenosis like we saw. Here will be a complete cellular and sclerotic stroma. Lobular arrangement, half-a arrangement, compressed lumens as I said. So it's a very close DD for tubular carcinoma and have a uniformly rounded glands in microglial adenosis. See, if I make a mistake between these two, it's not much of a problem for me because both of them are benign lesions. I'm not going to worry. I won't have a very drastic change in the management. But definitely I'll be worried when I misdiagnose microglial adenosis versus tubular carcinoma or a sclerosing adenosis versus tubular carcinoma. So tubular carcinoma is a very important thing because though it is a low-grade malignancy, it needs a mastectomy or a quadrantectomy based on the person. A radical surgery is required for them to have a long prognosis. Fine. Third thing, we're going to differentiate between apocrine adenosis and microglial adenosis. Again, these will not have a drastic change in the prognosis, but these are classical terminologies. I should not miss them, right? In myoepithelial layer will be present, might be even hyperplastic in apocrine adenosis, be completely absent in microglial adenosis. The shape of size will be variable. In the apocrine adenosis, why I put this table here is, we'll have a luminal apocrine differentiation. Here I won't have an apocrine differentiation of metaplasia, but you should not mistake the secretion for an apocrine differentiation because in the apocrine, you'll have an extra apical luminal pink color secretion that might sometimes fall off into the lumen. Don't mistake the fallen off secretion for a collagenous secretion in your microglial adenosis. Please don't mistake that. You should be able to differentiate them. So don't decide with one gland, look at many glands. If you can see secretions in many glands, I'm going to go for microglial adenosis. So only in the apocrine thing, I'm going to prefer an apocrine adenosis. EMA and GCDFP positive, here EMA and GCDFP negative. This is again important. Again, apocrine adenosis is not a main differential diagnosis for microglial adenosis. It might be a differential diagnosis for a secretory carcinoma of breast. We have something called a secretory carcinoma of breast. Maybe a few times later when we start reading breast pathology in the Unacademy app, the lectures, we'll see how to differentiate them. GCDFP is a very, very important marker for breast differentiation. Fine. The last table for differentiation, microglial adenosis versus a tubular carcinoma of breast, tubular adenoma of breast, right? It's not carcinoma, it's an adenoma. So the only main difference for me is I'm going to have myoepithelial layer. When I have myoepithelial layer, I'm going to brand them as a benign lesion, and adenosis will not have a myoepithelial layer. Though it's a benign lesion, it will not have a myoepithelial layer. Fine. You'll have normal elements surrounding a microglial adenosis, like we saw. The first image had normal TDLU. Then I had these scattered adenosis as well. Here, the normal is a mass, it's an adenoma. It will disperse all the things. So I'll have an adenoma like this. Surrounding them, maybe I have the normal elements, but not interspersed with them. So generally, the normal elements will not be there in a tubular adenoma, and they are circumscribed. It's an adenoma. You'll see the circumscribed finding, and you'll have more densely packed glands as compared to my microglial adenosis, where it's half-a distributed. Fine. So these are differences what we are going to see with this case. What we did here was we saw a case of a classical microglial adenosis. We went ahead with the histomorphology. We differentiated them with tubular carcinoma. We differentiated them with the sclerosing adenosis, with apocrine adenosis, and with tubular adenoma of breast. Right? It's a very, very important thing if you're going to practice breast pathology, and I hope you will not make a mistake in future, neither in your reporting or in your cases if it comes in your exam. Fine. Okay, that's the end of today's discussion. And as I said in the starting, we have lots of special classes available for you, and all these classes are free for you. Please download the Unacademy app and follow me there, and we can see lots of them together. Right? And as I said, these are all special classes which will be available free for you, and you'll have a live interaction. I urge you to attend it live. It will be after your routine working hours only. It will be at 7 or 8 p.m. in the night. The only thing for live interaction is you make mistakes here. If it's a mistake, you will not forget it, and you will definitely not repeat it in future. so that either in your exam or in your practice when you come outside, you won't make a mistake, fine. And you can download all the PPTs what I put there in the form of PDF. You can have it with you. You can have it for the reference. You can store it also, and you can attend in your laptop or in your tablet, wherever you want, fine. So see you soon with another pathology nugget. Till then, bye bye from Dr. Ranjith. Bye bye.